Good afternoon, Dr. Rock here. Dr. Matthew Ketman Family Practice here for Dr. Rock's Family Practice podcast. And I have a wonderful treat for you guys today. We have in the studio today Dr. Melissa Garrett, local general surgeon, friend, mother, wife, and entrepreneur. Hey, welcome to the studio. How are you doing today?
Great.
Awesome. Thank you for coming in today.
No problem.
I have been trying to get you into the studio or thinking about it for a long time, but then actually when I sent out a memo, you volunteered. So that's awesome. But I've been wanting to pick your brain for a while. So thanks for coming in.
I'm happy to do it.
So tell us a little bit about your background, what I like to say, your superhero origin story. I'm a comic book nerd. So I want to know where you came from, how you got to be a doctor, how you decided to be a surgeon. Tell me about your family. Just take the stage.
All right. I'm originally from Texas. I didn't know where Iowa was when I moved here. It's somewhere in the middle, right? I started out when I was really young. Actually, my medicine journey began when I was about 4. So my mom bought me this little play school plastic microscope, and my dad put a mosquito underneath it.
Awesome.
And all of a sudden, I realized there was a world out there that I had never seen before, and the veins on a leaf and all that kind of stuff. And I was just hooked. By 7th grade, we built a working pumping heart out of barium pumps with red and blue dye.
At school?
That was my 7th grade science project.
Cool.
So big nerd. Yeah, big nerd. And so
a lot of that are around here. That's fine.
It's true. Hey, we rule the world. So anyway, I just always wanted to do that. Life got in the way, details that don't matter. And so I figured out after a biology degree, which is worthless, that I needed to get a job. And so
one of those,
a couple of them. And so I went to scrub tech school. So I was a scrub tech for nearly 10 years in the operating, fell in love with it, wanted to do more. And so then I went to nursing school, got a bachelor's in nursing, did first assisting. I flew in the helicopter. I dabbled in medical sales, doing spine tech, which is like spinal hardware stuff, and said, I can do that. Let's do more. And so then I went to medical school in my 30s. And here I am still with school debt in my 50s. So there it is.
I was going to ask, you're not in your 30s?
God bless you. No, your checks.
You look so good. I can tell you're taking care of yourself.
Right. Checks in the mail. But anyway, so I went to medical school, and I always loved, from being a scrub tech, I was always fascinated by how the body works and how the insides come together and work. And it's an amazing miracle that I believe that more things don't go wrong. Anyone who doesn't believe those are miracles needs to see all the things that can go wrong and how they usually work well together, which is pretty amazing to me. And so I always wanted to do surgery. And so I became a general surgeon because I like variety. I get bored easily. And so it always is something new every single day. And even with the same problem, there's always new things and new anatomy and new ways to, even technology, to take care of things. And so it's just it keeps me on my toes.
Awesome. How long have you been in the Cedar Valley?
I moved here in 2018 when I finished my critical care fellowship because I'm a glutton for punishment, and decided to turn a 5 to 7 year degree into a 10-year degree. So I did research and a fellowship. And so I'm actually double boarded in both general surgery as well as critical care.
That's awesome. And do you use both?
I do. So whenever my patients or my partner's patients are in the ICU, I can help take care of those. I actually do locums in Fort Dodge for the critical care as well. I run the ICU out there once in a while just to keep my skills sharp. So yeah, it's a lot of fun.
So tell us what a day in the life of a general surgeon looks like.
That's a loaded question. So every one of my days is different, but the days themselves are the same, as far as my Mondays are the same and Tuesdays are the same. But at the end of the day, it's some combination of some clinic time where I'm seeing patients in the clinic who are referred to me by primary care or the emergency room, and try to figure out what's wrong and how can I help, and am I the right person for the job, versus going to the actual operating room or a surgery center or something like that and performing procedures.
So 50-50?
Pretty much. So my Monday's a 50-50 clinic. I'm Waverly in the morning and Waterloo in the afternoon. Tuesday is all day Waverly OR. Wednesday, I'm in the morning at the ASC, in the afternoon in the clinic. Thursdays, I'm all day in the OR. And then Friday is clinic.
Okay. Now that sounds like a rough life. I know that cold can be really ridiculous with general surgery. And I avoided surgery residency type stuff because I didn't think I could live that way for the rest of my life. So how have you adjusted? And you have children and you're married, right?
Correct. I have an 8-year-old daughter and 2 stepsons that are now just turned 20 and 16. And then husband. Yes.
Is that hard to be a general surgeon, taking call and being a mother and a wife?
It is. It's easier when you have a really good partner. So I'm very blessed that my husband's in the medical field and understands that I work harder than he does. And so he's incredibly understanding that if I'm not home on time or I'm missing a ballet recital or a dinner, that's just the way it is. So I'm very blessed with that. So I think having the right people in your life that support you is huge to knowing that this is my calling and it's what I love.
And he's a anesthetist, right? Anesthetist?
Correct. Yep.
Yep.
Or
That
either easier version is CRNA, but yes, he does.
yes.
He does
And
anesthesia.
do you guys work together?
We don't right now. We have in the past. It's actually how we met. It's a funny story, but we met in the operating room actually.
Was one of you working on the other?
No, he was
Okay.
no. So the backstory to that was, so I'd been, like I said, a scrub tech for 10 years, a first assistant, a nurse. I'd been in the OR for 15 years before I started residency. And he was the anesthetist, and I walk in as the second year resident in July when all the residents change. And he just thinks I'm some dumb second year who's an intern last week and didn't know what I was doing. And my attending, who did know my history and background, we were doing an umbilical hernia. It was a real tiny one. It didn't even need mesh. It needed one stitch. I turn to anesthesia, communicate with my team, and I say, hey, this is going to be quick. And he rolls his eyes and probably sits down with his Sudoku and figures he has an hour. And I was 8 minutes skin to skin before I was done. And so I turned around and said, I'm done. And he jumps out of his chair. Oh my gosh. And he hadn't turned off the gas or done any of that. And so then I started heckling him about how he couldn't keep up and that sort of thing. And we realized we both were smart Alex and could give each other a hard time, and neither one of us got offended, and the rest is history. So
that's awesome. Okay. So then do you guys start dating, and then did you graduate residency? Were you married, or how does that look?
Yep. So we started dating. We got married during, I guess, a year to about 2 years into that. And then we did in vitro and had our daughter. And that was during my fellowship year. So I got to do my chief year with a newborn, that was probably the hardest year.
Wow.
Yeah.
I cannot imagine.
Trying to be breastfeed and pump while you're writing notes. And it was lots of fun. Not. And so then this was actually my first job. So another anesthetist that he works with found out that I was graduating, and Dr. Garrett, who she worked with, they were in desperate need of a surgeon, and he called me up, and here I am. So the two of us.
So grateful that you are. So well, thank you for all you do for this community, and thanks for the background story. That's really not a direct route to surgeon. It was all heading in that direction. And do you think that your experience outside of medical training, I mean, in the surgical tech world, et cetera, do you think that, and the medical sales even, do you think that helps you today?
Absolutely. Probably my nursing helps me the most. I think that I approach patients a little bit different than maybe somebody who went straight from high school to college to medical school to a job and has really never taken care of patients prior to that. I did a lot of the doctor translation where the doctor comes in and uses all these big words and leaves, and then the nurse translates what he said. And so I think I can communicate with patients well at a level that they can understand, but yet get across with the important parts of things. And then also just a completely different approach. A lot of physicians might come at things like, okay, here's your pill for this, or here's your treatment for that. And I have conversations with them, and I realize that medicine is so much bigger than this medication. It is about a family and in the community you live in and how everything works together. May I give an example?
Please do.
Okay, so I have two, and I actually use this in my interview. So I am a little dumb medical student who supposedly doesn't know anything, right? And you stay quiet and speak when spoken to. And we had a patient this was in Texas. And so he was a Spanish speaking gentleman who was recently diagnosed with diabetes. He probably had a third grade education. He worked construction, and he kept returning to the emergency room in what's something called DKA, diabetic ketoacidosis, where your blood sugar gets super, super high and you get very sick because oftentimes it's not controlled with medication. And the general team had a bad attitude about him. They kept saying, oh, he's just non-compliant. He doesn't want to take his meds. He doesn't want to do what we tell him to do, and brushed him off as just being a problem patient. And I walked in as quietly behind closed doors and just said, have you ever seen a diabetic educator? Have you ever talked to a nutritionist? And they had just given him his prescription for metformin and sent him out the door. And so, of course, he went home and had the same beans and rice his wife had always fixed, and did the same lack of activity or whatever it was he'd always eaten and always had, because that was his family life. And they weren't educated that this is a big this is a lifestyle problem. This is a lifestyle change, and it's a lifestyle for the whole family, and they all have to be in support of one another. And of course, he'd said, no, I don't even know what you're talking about. And so we brought in the wife and we brought him a nutritionist who could speak Spanish, and we gave him recipes, and we never saw him again. He never had to come back, and he was able to be a part of his own family and his own life without now understanding it's more than just a pill. And not a single one of the medical providers had even offered all of those other adjunct things that are available because they just hadn't thought about it. They gave him his prescription and sent him out the door. And then the other example was
That's still a thing, isn't it?
It sadly is.
People still do that today. We still see that.
Yeah. And education takes time. And that's, I think, a lot of the problem is we talk about all these Medicare cuts and all these kinds of things. And we as physicians have mouths to feed in our own household and bills to pay. And so it's about seeing more patients. But the problem is that education takes time. And if we don't take the time to educate our patients, we are the most important educator for our patients. And that's the way I view my practice is I will take the time till you understand how you can help yourself, because you're never going to get better unless you help yourself. But sometimes people just don't know. It's not that they're not willing. They just don't know. And they're not trained the way we are. And they need to have that information, but explained in a way that they can understand. My other example was real quick. I had
awesome.
A young mother. She just delivered a baby, and the crew was walking through and just merely saying, are you going to breastfeed? Or are you going to bottle feed? Are you going to breastfeed? Or are you going to bottle feed? And they were just checking boxes, which again, no judgment either way. It's your choice. It's no problem either way. Anyway, she said, well, I'm going to bottle feed. And so I walked back later, and again, no judgment. It's fine. Just curious why you don't want to try breastfeeding. And she said, I don't know how. No one had said there's a lactation specialist who will come talk to you. And if you don't want to, or you can't, that's fine, but don't do it because you don't know how. Walked in the next day, kid attached, feeding like a champ. They were happy. Everything, kids healthy. Everything's going to go just fine. But nobody had taken one more step and said, can I help you understand this better? And I think that's our job as physicians. It's not only to treat them, but it's to educate them.
Wow. I love that. Hey, real quick, this is for my editor. Do you hear your voice when you're talking? Can you hear yourself in your headphones?
Yes. Am I supposed to?
Okay, so
but
not
reverberating
supposed to be able to hear. No, but I'm hearing you cut out at times. So I didn't know if it's just my end or your end. Like when you're talking, does it sound like you're talking to in a megaphone or a microphone? Can you hear your own voice?
Yes, I can hear my own voice. It doesn't sound cutting out to me.
Okay, it must be just on my end. I just hear I think it's let me unplug my headphones here. If you have to take a call or something, go ahead.
No, I'm sorry. I'm just looking at a Epic chat.
Oh, take your time. We already got some great material. Okay. All right. Yeah. So I'm going to have you walk us through a typical day, maybe in the emergency room, maybe in the inpatient floor and outside of the clinic, and just let people know what kind of cases and what you do.
Okay.
What general surgery consists of.
Sure.
Actually, while you're checking that, I'm going to get some more water.
I hate Epic chat.
I don't use it. I hope nobody tries to get hold of me through it.
Oh my gosh. You're way too accessible. It's infuriating. Anyway.
So far, it's going great. So great job. Okay. We'll just pick it right back up. Okay. So why don't you take me through a typical day? I know you have to deal with the ER. You have to deal with patients on the floor. And when you take calls, sometimes that can be really hard. And just tell us what maybe a tougher day for a general surgeon in Waterloo would look like. And so we can get an idea of what you do. I think people know what I do. But I think when it comes to the surgical specialties, I don't think they understand quite as well.
Sure. I have two kinds of days. I have clinic days and I have operating days. So a clinic day would be I come to the office and they line up patients and we have conversations about maybe they're coming for belly pain or they're coming for any number of other referred from primary care or the emergency department for the consideration of surgery, because not everything needs a surgery. And that's part of the job, is deciding who needs a surgery, what kind of surgery, timing of that surgery, or maybe not a surgery. And so that's a little more of some mental challenge day of people start talking, oh, I have belly pain. Okay, where? And I have to go down some sort of tree or pathway of getting to the root of the problem, because people describe things in a not medically educated way. And so I've got to try to translate and figure out if there's a way I can help them. So that's a clinic day. For me, those are exhausting just because I'd rather be operating. That's just what I like to do. But it's a part of the job that gets us there. And it also is the one that's the most important. And I think the hardest part is making sure we do the right operation, if there's an operation, on the right timing. And then an operating day for me, I operate on Thursdays. And so that's also my call day, which is the way I've designed it, so I'm already at the hospital anyway if something comes in, whether that be a consult or an emergency. And so I do robotic cases. So on the robot, which is like the newest, latest, greatest of laparoscopic surgery, the minimally invasive, just the poke holes with the camera, I can do take out gallbladders, I can fix hernias, I can do colon resections, we can do all kinds of things on the robot. Or we can do open surgery, hernias, hemorrhoids, any number of, we do amputations, we can take off melanomas. The nice thing about general surgery is it's a little bit of everything, thyroids, any number of things we can do. So it's like I said, that's a fun day for me. And I don't mean that in any disrespect to someone's medical problem, but in that it's a variety. It's always something new and it keeps me always thinking and using that part of my brain. That's my call day too. So that day can get really long. With last night, I had an appendix at 8 o'clock, and then we had a stab wound to the chest at midnight. And you have the potential for being awake for 24 hours. That rarely happens, but on occasion. And
So this sounds brutal. What draws you to this?
just the fact that I'm helping people, the fact that I am directly a part of making them feel better. A lot of it, this sounds really funny, is I'm a short-term goal, immediate gratification person. I'm not a marathon runner. I'm a sprinter. And so I remember in medical school, I really loved cardiology a lot. I really liked the heart. It fascinated me. I scrubbed hearts as a scrub tech, and that's what I first assisted. I really thought that might be where I was going to go. And I was in my medicine rotation, and the medicine doctor said, okay, those silly surgeons, they just want to be done. In medicine, it's never done. And I vomited in the back of my throat and said, nope, not for me.
Gotcha. Yeah.
For me, you have bad gallbladder. I take it out. You're all better. Yay. I like that there's like a checkbox. Like I can make you better in an operation for the most part. And then you walk away and you are a better person of yourself and you feel better and life goes on. And I like things with my hands. So when I have medical students, I do this whole little decision-making tree with them of, okay, who are you and who are you really? And be honest with yourself. Because if you're an introvert, my job, your job, that's not for you. I talk to people all day long. I interact with people. I've got to be able to connect with people. And if people drain you, go into radiology, go into pathology. There's plenty of ways to be a part of medicine and be honest about who you are, what charges you, what gives you energy, and what drains you. And that's, you start with the introvert extrovert version. Then I say, okay, what kind of things did you do as a kid? Did you play with blocks? Did you build things? Or did you do word puzzles? If you like the more mental side of things and you like to read and research, something in the medicine field is more your thing. If you built models and you like to play with blocks and you like to do things with your hands, then something on the more procedural side may suit you and what you like. I have people who are plenty smart enough to be surgeons, couldn't throw a dart and hit a wall if they had to. You don't need to be a surgeon if you can't use your hands. And there's got to be a lot of it's trained, but some of it has to be that innate joy of doing things, procedural type things. And then within that, there's all kinds of variations that can fit just about anybody. Like I said, I like the variety. I like that I get to use different kinds of technology. Like I said, everything from a scalpel to a robot. There's just all kinds of things to do. And I don't mind the call. My dad was a race car driver. I like the adrenaline. The trauma doesn't bother me.
For real?
Yeah. Yeah, he was.
Tell me about that.
He sold insurance as his real job, and then raced what's called SCCA, which is this, I don't know, Southern Car. I don't know. Anyway, it's a road track. So not circle track, but variations on a track kind of thing. First rode Atlanta and all kinds of places. And I guess maybe a little adrenaline's in my veins. I like that. I like trauma. I like not knowing what I'm going to do till I get in there and I have to think on my feet. I love that. The other thing, the other example I give my medical students is, how do you like to make decisions? Because part of being a surgeon is you have to make a life or death decision without all the information, and you have to be okay with that. And that's really hard for some people. My husband, for example, it's going to take him a year and a half to decide which car to buy, and he's going to research it to the point that now that car's not the same car as it was because now there's a new one. If you're that kind of person, you need to be in medicine. I went post-call, no sleep, to the car lot and said, the white one looks good.
That's probably the best explanation I've heard of the difference between surgical specialists and medical specialists. Thank you for that. Okay, awesome. I'm going to get to some technical questions here. I want your opinion on gallbladders and gallbladder disease. I see a whole bunch of variation all over the board about how this is handled. There's definitely a difference in philosophy. So the gallbladder, if you could explain a little bit about what it does and how it becomes a problem and what we do with it. And then I kind of want to, I see just almost 180-degree difference in how gastroenterologists handle gallbladder disease and how general surgeons handle it. It's almost like the gastroenterologists it's the last thing they're going to do is have you take out somebody's gallbladder. And sometimes I think they would say that the surgeons are in a rush to take it out, but sometimes I think they also don't do it soon enough. So can you give me some feedback there?
You bet. So I'll back up a little bit and I'll give you the same spiel that I give my patients, and my nurse knows it so well because she can quote it now. So here we go. Liver makes a substance called bile. Bile's a soap. Soap breaks down fat, just like Dawn in your dishwashing liquids, so that we can absorb it. Thank you very much. I usually pat my hips in that moment, as opposed to it running through us as greasy diarrhea. Okay. So you've got to be able to store it. While there are good fats, omegas, those kinds of things, fat is fat as far as your body's concerned. It doesn't know the difference between a Snickers bar and olive oil, and it's going to break down an oil and a fat in the same way. And it needs a soap, which is bile, to do that. Gallbladder is just a holding tank. All it does is hold it and squeeze out a proportionate amount based on what you eat. So there's a calculator in your brain. So when you eat Culver's or pizza, maybe you need a couple of tablespoons of that stuff to break that down so that you can store it for winter months or whatever. As opposed to you have a grilled chicken salad, maybe you only need a teaspoon of that stuff. So the gallbladder can proportionally contract and squeeze out a little bit or a lot of that stuff so that you can break down the food that you eat. That usually happens and starts within about 10 or 15 minutes of eating a meal. All that communication happens. With gallstones, what happens is when we eat a lot of fat in our diet, the liver is filtering everything, and it's going to, or have high cholesterol that's uncontrolled with whether that's medication or diet or exercise or whatever. All of that fat sort of gets deposited in the bile, and then you've got this holding tank that's just hanging out waiting to use it. So the bile kind of sits around for a little while. Then it rolls around, and just like a snowball, those little tiny bits of cholesterol collect together, and then they collect together and get bigger and bigger until they form a gallstone. Excuse me. There's a couple of different things that make up gallstones, but cholesterol or fat is the most common source of a gallstone. So then what happens is, because it's this big dome, it literally looks like a kid's balloon that you've started to blow up, and it's all stretched at the top and little bitty tiny neck. The gallbladder tries to contract when it gets the notion, hey, there's pizza in here. And so when it does that, when it squeezes, like I said, it's a big dome with a little bitty tiny neck, and the ball rolls over the hole and works like a ball valve. When it works like a ball valve, now the gallbladder squeezes against a brick wall, and that's when people have that right upper quadrant pain. That's what we typically say. Do you have any right upper quadrant pain? In other words, right under your rib cage, right on the right side. People can usually point with one finger, it hurts right here when I eat Culver's or I eat burritos or something like that. Is a gallstone getting stuck there. Usually what happens within 3 to 6 hours, the gallbladder relaxes, that stone rolls away. The gallbladder can now passively fill and contract when things leak out and do what it's supposed to do, and the pain goes away. So people will say, I don't hurt when I eat this, or I don't hurt when I'm not eating. I don't hurt first thing in the morning because I've now basically fasted all night long. I hurt when I eat X, Y, or Z, and it's usually some version of a fatty food. Sometimes little bitty stones can roll down the pike, or small enough to get down those pipes that lead out of the gallbladder and get stuck inside the pipes. It's a big giant network. It's just plumbing, basically. You have a pipe from the liver, a pipe from the gallbladder, and a pipe from the pancreas, and they all converge into one pipe that dumps into your small intestine, which is where all the digestion happens. If anything gets stuck in there, that's where the gastroenterologists come in. They can't do anything about the gallbladder, but if a stone gets stuck in one of those pipes, they can put a camera down the mouth called an EGD, and they can go fishing. They can basically go fetch that stone out. But all they're fetching out is that one stone that's causing a problem. There's still a whole bunch of them uphill that can cause another problem tomorrow or whatever. And so that's where surgeons come in with saying, okay, this has happened once. It's probably going to happen again. We should probably take your gallbladder out. The one caveat to all that is not all stones are the same, in the sense of owning a stone does not mean you need your gallbladder out. If you didn't have, so this happens all the time. Somebody has a car wreck. They get a CAT scan because they're in the trauma bay, and that's what we do to people. And they happen to find gallstones. This person has never had right upper quadrant pain. They eat pizza last night. They feel great. They have no problem with that whatsoever. They go see their primary care doctor, no offense, and they say, hey, you want a gallstone? Go see a surgeon. So they come to me and I say, hey, do you have belly pain? And they're like, nope. Does it hurt when you eat pizza? Nope. When did you have pizza last? Yesterday. How was it? Delicious. And I say, you don't need me. So you can absolutely die with your gallstones with no problem, as long as they aren't causing problems. The moment you start having pain, that's a different animal. Now we go take it out. There's no way to dissolve stones. There's no medications that dissolve stones. There's no way to get the stones out of the gallbladder. It's just take the whole thing out, kit and caboodle.
What about ursodiol?
Doesn't work.
Just wanted to clarify. That's a drug that people have proposed to dissolve stones, but I just wanted to make sure it didn't work.
It doesn't
So
work.
being the primary care, I'm just going to say for the record that Dr. Cack, who trained all the residents, told me I was the best he ever had. So I don't send asymptomatic gallbladders your way. So anyways,
You're right. I don't think I see your name on it.
nah, but let's talk about the philosophy of gallbladders, because sometimes I'll see people in the workup, if they're gastroenterologists, doing things differently. And it seems like they'll do SIBO testing and et cetera, long. And then maybe down the road, let's talk about looking at the gallbladder, getting a HIDA scan. I don't see a lot of HIDA scans owned or ordered from the gastroenterology office. And I've always wondered if it was a philosophy difference. If they're more of, we need to keep our organs. Is it okay to take out a gallbladder? Can you live without it?
Maybe you see more than I do. I feel like they send me all of the belly pain every time that might have a gallbladder. And so I feel like I see them a lot. So HIDA scan, that is a test for the gallbladder function. So gallbladders can cause you problems in two ways. One, stones, block the ducts, basic plumbing, clear the ducts, get the gallbladder out. The second version is the gallbladder can just not work right. So what a HIDA scan does is test its ability to squeeze. So we want,
and this is, Wendy, would you order this? This would be someone who you've looked at an ultrasound and they're having problems and you don't see a stone, but you're still, boy, it sounds like gallbladder.
Exactly. So they come in with nausea, vomiting, diarrhea, sometimes right upper quadrant pain. It's not related to any food that they can figure out. They have an ultrasound or a CAT scan that show no stones at all. But all of their symptoms are belly related. Lots of times that's the harder one to diagnose. And so I think that's where gastroenterologists will try to narrow it down by
an EGD.
That's where they put the camera down the throat, look in the stomach, look in the very, very first part of the small intestine. You can't get very far down the small intestine, but a little ways. And that's where they're looking for ulcers and that sort of thing that would put you on one of those acid suppression type medications. If you're having to take Tums every single day and the pain is in the middle, right under your breastbone in the center, that's probably your stomach, not your gallbladder. Gallbladder is pretty typical being on the right side. Now, stones are more typical than one that just doesn't work. So sometimes it's a process of elimination when you don't own stones, but your gallbladder doesn't work very well. But the HIDA scan is a really handy tool because what it does is tells us something called an ejection fraction. And what that means is how vigorous your gallbladder can contract. We have a kind of a set range, and it's an ish of about 30 to 35% to about 70 to 75% is quote unquote normal. Below that, and having no symptoms, nobody cares what the number is. If you can eat pizza and you can eat and you're not sick to your stomach, and other than like when you eat, okay, everybody has that one food that doesn't sit right. If you got to have tacos, you got to have tacos. You can judge.
No, but gotcha.
For the most part, if you're eating your normal diet and you don't have any belly pain, it doesn't matter what your number is. It doesn't matter if you have stones. We're talking about people that are symptomatic, meaning having belly pain, whether that be specific pain or nausea or vomiting or diarrhea, or stools get really weird color. They'll get very light colored and they float. I know that sounds weird to talk about poop, but I do it all the time. That means there's a lot of fat in your stool. That means that fat is not getting broken down. So the fancy smanchy term is called STIA, but I tell people, I point at my wall that's taupe and said, does your poop look like that? And if they say, oh yeah, it's like that and it floats, it's really weird. There's too much fat. That means the bile is not getting into the small intestine for some reason or another. So again, the HIDA scan tells us how well it squeezes. If you're having these symptoms and it's 12%, your gallbladder is like the lazy bum that's not doing what it's supposed to do. Some people can actually have a hyperactive gallbladder. We see this more in teenagers and early 20s. I've even seen it as young as 10 or 12, where their gallbladder squeezes with such ferocity, like they'll have a 97, 98% ejection fraction. It squeezes like the Hulk. That also can cause a significant amount of pain. We do take gallbladders out for merely being dysfunctional, because the funny part about it is we know there's a connection between the liver and the gallbladder in that the liver knows it owns one. It doesn't know how well it works. It doesn't know it's blocked. It doesn't know it's not functioning at its top capacity. It just knows it owns one. To your question of can you live without it? Absolutely. But there are some changes. And what that means is once you take that holding tank out, I tell everybody, you ate a low fat diet for a while, let your liver heal, give it time. And the first time you try pizza, you do it in the privacy of your own home. Because what can happen is without that extra abundance of bile in the holding tank, your liver has to learn to ramp up production. And it will, but it takes time, like 6 months to a year. By about a year, if you get diarrhea with tacos and you have to eat tacos on the toilet, no judgment, totally would do that. But it's going to take a while for the liver to learn, oh my gosh, it's now up to me to make bile on demand based on what's coming down the food pipe. And that's the biggest downfall is some people, I tell people about a third of my patients could go eat pizza the next day, no problem. About a third of my patients can never eat certain number of foods ever again without having diarrhea. Most people are somewhere in the middle, have a little bit of loose stools in the beginning with certain foods that are very fatty, and that gets better in time. And they just know there's certain foods you don't eat on the road in your car. There are certain foods, but I tell everybody before you're going to take that cheeseburger to work, you have it at home first and see how you do. If it does give you some loose stools, give it a couple of months, try it again. It will probably get better.
And there's medicines. So you can get your gallbladder out, and that can relieve a lot of symptoms for some people if it's a problem. But if they do end up with diarrhea, there are medicines that help. You can get a bile acid sequestrants, I believe.
Yep. We usually don't recommend doing that before a year because everything is changing in your body. Your body's getting used to this new, I've got to ramp up production. You want to give it a chance to do that. But absolutely, after about a year, especially for people some people have this terribly and they have diarrhea or loose stools with every single time they eat. And yes, there's special medicines that will help hold onto that bile and try to concentrate it and help you be able to break down food. They work pretty well, I think.
And is diarrhea hereditary? It runs in my genes. Nice. All right. Hey, okay.
So poop jokes. I love it.
Yeah, I like it. Okay. So listen, the other thing I want to talk a little bit about though, is there's a number of people I've come across who, okay, maybe they've got the risk factor. So they're maybe a little overweight, they're in 40s, 50s and whatnot, and they're having this pain in the right upper quadrant or nausea when they eat right under the right rib. And then they get the ultrasound and it's negative, but the providers, okay, let's do a HIDA scan. They do the HIDA scan and that's in the normal range, but they still need their gallbladder out. And this is a debatable topic. And I wanted in my opinion, because when they did the HIDA scan, even though the range was normal, they reproduced their symptoms when the CCK was injected. What do you feel about those people?
So there's one other thing, and it's the unicorn in the biliary world, in the gallbladder world, and that is called sphincter of Oddi dysfunction. Very cool. It's one of my favorite body parts. That is the little sphincter, the little muscle that controls the emptying of all of that pipe of stuff, the liver, the gallbladder, the pancreas, into the small intestine. And it can spasm. So that's what that CCK often does, is triggers a spasm in that muscle. There are people who just have that spasm. It is a really hard thing to diagnose because exactly what you said, every single test comes back normal. They can eat things, then they can't eat things. And so that's a really, really tough one when it's that, because taking out your gallbladder doesn't help. If that's what it is, that's where gastroenterology can sometimes see that when they do that EGD, that camera down. Sometimes they can cut that sphincter. It's called a sphincterotomy, where they basically cut it open and make it a little bigger so that it can't really spasm completely closed. But it's a really tough diagnosis to manage because it's hard to diagnose and hard to treat and just unlucky. And then that stinks. But as far as reproducing their symptoms with the CCK, I don't know how much of that is that sphincter of Oddi reproduction versus it being a true gallbladder. For the most part, I feel like what I don't want to do is, let me back up. Gallbladder surgery, like any surgery, is not free in that there are always risks. There are always complication possibilities. And some of them in gallbladder surgery are big. They're big. So if things are very inflamed and in the process of trying to dissect around things that are solid because somebody has ignored their right upper quadrant pain for many years. So this happened in COVID. Nobody could get in to get an elective surgery for 2 or 3 years. People had gallbladders that were just getting worse and worse. And so the gallbladders we did right after we could start doing elective surgeries again were awful. They were terrible. They were stuck. They were inflamed. And when that happens, it distorts the anatomy. So the risk is just like driving your car, you could crash. The risk is when I get in there, you can cut the wrong thing or damage the wrong structure. And when that happens, it's a major replumbing operation. You got to go to the University of Iowa or Mayo. We don't even do it here. It's a big thing. And so I never take any operation, but especially gallbladder operations, lightly, just because I usually can get it out pretty easily in under 20 minutes. Doesn't mean you won't be the one that something could go bad. And then on top of that, I've now potentially given you diarrhea for the rest of your life.
So if you have a patient with classic symptoms, classic presentation with normal ultrasound and normal HIDA scan, have you taken those people's gallbladders out before?
Nope, won't do it.
But some of your colleagues do.
I can't speak for them.
Okay, I'm just wondering because I believe it's helped some of my people when they've been end of the line, and I just wanted your take on it because I know it's very controversial. So
it is, because again, I don't want to. Now you wake up, you have the same pain. Hopefully you had no complications, but you wake up with the same GI pain, because I guess part of that is making sure we've gone down every other rabbit hole possible. So things like gastroparesis can mimic gallbladder type symptoms where they have early satiety, nausea, vomiting, don't feel like they can eat very much before they get sick to their stomach. That's probably my most common second test. If all of those are negative, then the next thing I send them for is a gastric emptying study. And I've diagnosed a ton of people who didn't know they had gastroparesis, which means your stomach doesn't work very well. It's very slow. It's very sluggish. You're not processing the food. You feel full really quickly. And most of the ones that I have said, okay, let's go down some other hole before I take your gallbladder out for no reason, almost all of them have been some degree of that sluggish stomach. And so I think that if you've done the camera down, they don't have ulcers. You've done that gastroparesis study. They don't have that. You've done SIBO, which is that overgrowth of bacteria. I think if you've gone down every single rabbit hole possible as to why they're having problems, okay, maybe I would, but I have not ever had that. We've generally found it at some other point.
Okay, I appreciate that because I wanted to hear your perspective on that. Do you perform EGDs and colonoscopies, or what people know as scopes?
Absolutely, I do. I did 5 this morning.
And why would we have you do that instead of a gastroenterologist? And what's the difference?
So hopefully there is no difference. Sometimes it's just a matter of anytime we're going to do an operation. So for example, I think if you have, so oftentimes the gastroenterologist finds a polyp or finds a mass in the colon. They'll send us to the surgeon to evaluate them for surgery.
They do a scope and they find a tumor, and you take care of cancers in the colon. Right. Okay.
Yeah. So they send them to me and we talk about a surgery. Sometimes they get chemotherapy first. The scope needs to be repeated. Sometimes once in a blue moon. So one of the things we can do when we find something that looks weird in a colon is we can literally give you a tattoo. It's a little bit of ink that we inject right by that spot that we can actually see through the wall. It helps us find
with the scope inside.
Correct. With the scope inside. So with the scope inside the colon, we can put a little tiny needle just inside the most thinnest layer of the colon, inject a little ink. And then when we come in from the outside of the colon, like in an operation, we can actually see that ink. Because if you think about the balloon animals, okay, the empty balloon is 8-10 inches long, and you blow it up and it's 5 feet long and turns into a giraffe, right? So that's exactly what happens with the colon. So where they think it might be blown up, and when I see it decompressed, can be very different places. So they may say it's on the left side and actually it's somewhere in the middle. And so that tattoo is very important to helping me find it. If they didn't tattoo it, so let's say it looked like a regular old polyp, they felt like it was not anything scary, and then the pathology comes back after it comes back from the lab, it turns out it did have a spot of cancer, and they didn't tattoo it. Sometimes we have to repeat that colonoscopy, which really stinks for the patient and bowel preps. I apologize. But we need to know exactly where we're going, because what we don't want to do is make incision in the wrong place or set up the robot in a different way. We want to make sure that we can do the best operation we can. So that helps us identify it. As far as screening colonoscopies, okay, it's been 10 years. It's time for me to have a colonoscopy. Hopefully we have been trained well enough by our training that you should get the same outcome, the same assurance that you are free of polyps or whatever from them or from us. I'm sure that
it's not a competition.
It's not a competition. We work together. However, but in truth, there are some that are really challenging. And sometimes it's down to the technology you have. So they have cooler toys than I have. So let's say you have a history of a really, what we call a tortuous colon. So one that's really twisty, really turny. They may have a scope that's more flexible than I have the basic kind of scope, or they have different kinds of wires and different kinds of little tools that take polyps out. So sometimes we will refer a patient. So let's say I do a colonoscopy and I couldn't get to this spot or something like that. I will send them over to them because I know that they do. I just did in Waverly, they had a big celebration. I got a cake with a poop emoji on it because I had just done my 1,000th colonoscopy in Waverly, but they do more than I do. Admittedly, they do it all day long, every day. And they do have those tips and tricks that if I have a really tough one, I call my GI colleagues often and say, help. And I'm not going to do something and push forward where I feel like it's unsafe. And so I'll send them over and have them do the scope. Or a patient that I had a really tough one this time, I'm like, okay, we got through it, but it was really hard. You're going to get to go see them next time. So I might donate some patients to them once in a while.
Gotcha. Hey, I'm going to go to the bathroom real quick. You need anything to drink?
No, I'm fine. Thanks.
All right. We got about 35 minutes left. You're doing great. So
Thanks.
yeah, no, it's great. I think I'm going to come back. I want to talk more about what you do, scope of care. So skin, pancreas, what kind of colons, breast, thyroid. I want everyone to understand why they would come see you, or if they should come see you, and we can promote you. So hold on. Notice I like controversial questions that cause a little bit of
That's fine with me.
By the way, my editor's name is Quinn. Quinn, if I said anything derogatory about gastroenterology, take it out. For real. Okay. And so the other thing is Quinn might take the end and put it in the beginning and make a story out of it. So it'll come good. Okay. So tell us, it sounds as a general surgeon, I don't know if it's as broad as primary care, but you guys will take things off skin. You'll do cancer surgeries of the breast, the thyroid. So it's not just working on people's guts.
Correct. That's the joy of general surgery, is it is anything and everything within some scope of what we've been trained to do.
Skin cancers?
Absolutely. Tons of skin cancers.
Yep.
We do everything from, so lots of times what happens with skin cancers is people go see their dermatologist or their primary care doctor. They get a biopsy that proves it's cancer. So what they do is then come to us after the biopsy's already been diagnosed, the cancer's already been diagnosed, and then we take what's called a margin. In other words, we get the rest of it all the way around. With regards to melanomas, for example, there's some very specific guidelines because melanoma is the only skin cancer that's going to kill you, and it's very dangerous and very important. So making sure if you have moles and freckles that you are seeing your
black and brown stuff. You see something that, it's okay, especially a new one or a changing one, right?
Correct. If you were born with it, it's never changed, it's probably just fine. If it all of a sudden starts changing, you should go see somebody, whether that's primary care or dermatology.
Or a new one pops up that's black and brown or both or either.
Yeah, and grows and changes. There's something called the ABCDs of melanoma. If it's irregular borders, those kinds of things. So when it comes to melanomas, we treat them a little differently because they're very serious. And we have guidelines from the National Cancer Institute's NCCN is who guides us with how much to take, whether or not we go look for a lymph node. Huh?
Who is CCN?
The NCCN is the National. NCCN is the National Cancer something. Somebody else can look that up. NCCN.
Yeah, just leave that out. Yeah. Sorry, I'd asked. All right.
That's okay. It's the National Cancer Guidelines. And so they are the ones doing the most research and culminating the most research about all kinds of cancers. So every cancer, they talk about melanomas, breast, colon, prostate, all the cancers. They're the ones who are the gurus. That's your standard of care for how do we treat this. And they change all the time. And so it's important that we are always watching for updates. We're always I'm on the website all the time about, hey, is this still the same way we treat a sessile serrated polyp? So a very specific kind of polyp we might find in a colonoscopy. So just like recently, they changed the guidelines for you started colonoscopies at 50. Now it's 45. That is because they realize we're catching polyps earlier and earlier, and we're saving more and more lives. So those are things that kind of institute does. So
melanoma, you guys are doing a lot of different cancer work. If there's a cancer involved, then there's a good chance there's a surgeon involved, correct?
Most of the time. So it's a collaborative effort between surgeons and oncology. So they run chemotherapy. Then there's a radiation oncologist if it's a type of cancer that would be amenable to radiation. So the three of us work together very closely. So we have something called tumor board, for example. And that's where the pathologist, a regular radiologist who's looked at maybe a CT scan, the radiation oncologist, the oncologist who might run the chemotherapy, and a surgeon all put their heads together in a think tank and take a patient that might be really challenging, who has a very unique cancer or very unique features, or it's in a certain place that's unusual. And we figure out with everybody involved with their own level of expertise, how's the best way to get these people to remission and life and moving on with life. And so we do a lot of different kinds of cancers, but usually never in isolation by ourselves. It's almost always with a group of really smart people who we all come together and work together as a team. So as far as other things,
what about thyroid cancers, breast cancers?
Sure. So general surgeons can be trained to do all those things. So sometimes in certain areas, There's people who are more comfortable or more expertise in different things. Here in the Cedar Valley, we have a breast specialist. That's Dr. Jason Gesme. That's what he does. And so we let him do his thing because he's done it for a long time. And he's the one who does that here. But in other towns, most of the time, general surgeons also do breast cancer as well. As far as thyroid, same thing. Sometimes general surgeons do it. Sometimes someone who's specialty trained in endocrine cancers do that. I do some thyroid surgery. I don't do too much thyroid cancer just because it requires a special dissection of a lot of lymph nodes, and that gets really complicated. And I don't do it enough that I would say that I wanted to be comfortable doing that. But goiters, cysts, those kinds of things, we certainly do here. Otherwise,
biopsy lumps sometimes. That's where I would send somebody if there was a lump under the skin that popped up. You would be an expert in that, correct?
absolutely. And so I do a lot of thyroid ultrasounds. I do a lot of fine needle aspirations, in other words, biopsying of thyroid nodules. So I do those all the time. I see 2 or 3 a week sometimes, and we can biopsy them with a little tiny needle and numbing the skin. It's very painless to make sure it's not thyroid cancer. Is it just a run of the mill nodule, which they're very common. So if you get sent to a surgeon for a biopsy, it's not a guarantee of cancer. Don't jump to conclusions. Always make sure that you get all the information. So yeah, little things, we biopsy lots of things to take out lymph nodes if we need to see if somebody has a certain kind of lymphoma or that kind of thing. Or maybe it's just you have a cold and you have a lymph node. So we do a lot of that. Yeah.
Do you need any cardiothoracic surgery?
Cardio, no. I actually am trained in rib fractures, and there's something called a retained hemothorax, which is fancy for maybe you broke a rib, you got some blood in your chest, you had a tube in your chest to drain it, but it didn't drain completely. That is at high risk for an infection because blood is full of iron and sugar and all kinds of yummy things that bacteria like. And so you can get a big infection around your lung, not in your lung like pneumonia, but around your lung. So I can put a camera in, just like a laparoscope, like we take out gallbladders, and get rid of that. So I do a very tiny dabble in the thoracic and the chest wall, but I don't do anything cardiac.
What about lobectomies of the lung? I know some general surgeons will remove lung cancer, small lung cancers.
No, nobody here does that. We leave that to the cardiothoracic surgeons.
Gotcha. Okay. What are some things that you've seen that you want to tell people about concerning symptoms that from your perspective and from your experience that people should not ignore that you've seen? Hey, I mean, there's some obvious things like blood in the stool, obviously, or I've lost a bunch of weight and I don't know why. But what are some, from your perspective, some symptoms that my patients or my audience might not be aware are concerning?
That's an excellent question. You had that on your list, and I was afraid you were going to ask that. So yes, blood in the stool is one. 9 times out of 10, it's a hemorrhoid until it's not. So always go get it checked out, either by your primary care doctor or your surgeon. Yes, weight loss that you're not trying to do is always worrisome. Loss of appetite that you're not trying to do with medicine or something like that is always worrisome. But when I was reading that question that you sent me, the thing that came to my mind is umbilical hernias that people already know about and somebody told them don't worry about. That can be a very dangerous thing because what can happen in any hernia.
We're talking little belly button hernias, right?
Yeah, or big belly button hernias, or any hernia for that matter. Anytime there's a bulge that isn't a lump, is not fatty tissue. It's from the inside because there's a hole in where your muscles keep your insides and your outsides outside. If things are bulging through there, that should not be ignored. That is not you'll be okay if it doesn't hurt. Because what can happen is intestine can get stuck in any one of those holes, whether that's in your groin, in your abdominal wall. There are even hernias in your back, believe it or not. And if bowel gets stuck in that and gets pinched, bowel can die. Bowel dies, then that's a major operation and can even cause death or a poop bag or any number.
I'm glad you said that because I literally was trained that the vast majority of umbilical hernias don't need treatment.
At bare minimum, evaluation would be good. But most of the time, what I tell people is if you own a hernia, you probably ought to fix it. Actually, interestingly, small hernias are more dangerous than big hernias. So if it's humongous, and when I say humongous, I'm talking golf ball, not the bulge, the hole in the fascia, that muscle layer. If that hole is a golf ball or bigger, it's probably okay in that whatever's going to come in and out is going to continue to go in and out and in and out. When they're really small, like a quarter or smaller, that's a dangerous hernia because stuff gets popped out and then it gets stuck because maybe there's bowel juice that gets in there. Or even if it's just fat, that can be incredibly painful. Fat has nerves, and that fat can die and become necrotic or dead, and that can cause infections and cause other problems. So I generally say if you have a hernia, you probably ought to find the time. It's inconvenient because we make you have a lifting restriction for a lengthy period of time. Nobody likes to do it. Nobody likes to not work out or go to work or do their job. So sometimes you can have the luxury of time, but it still ought to be fixed because the risk is everything in medicine is a risk benefit. If the risk is so high that something really bad like death can happen to you, then owning it is Russian roulette. If you're not every day that you don't to have bowel stuck in it is great until it's not. And that's what often happens is people might think they'll get it fixed one day, then they come in the middle of the night, the bowel's stuck in there, it's hard, it's firm, it's dying, and we have to do an emergent operation. At that point, you haven't done a bowel prep, you haven't been prepared for this. The bowel is very unhealthy. I have to take out a section of bowel. If you're lucky, I can put it back together. If you're not, you got a poop bag for about 6 months before we can put it back together. Really bad things can happen if bowel gets stuck in a hernia.
Tell me, just for the audience, tell me what a hernia is.
So, like I said, a hernia is where the muscle layer that holds your insides in and your outsides out has a hole in it. That could be so everyone's born with an umbilical hernia. Just the hope is that it closes up. You had to have an umbilical.
The belly button, right?
The belly button. That's right. So you had the umbilical cord that connected you to mom, and that is a hole in your abdominal wall and your belly wall. But the hope is after you clamp the cord and the baby grows a little bit, it's not uncommon for babies to have, so that's something else to talk about, for babies to have an outie, as we would call it, that little belly button hernia. That's pretty common up to about 2 years of age, but it should close down and go away by the time they're 2. So the rule of 2s for surgeons is 2 years old, greater than 2 centimeters, it's not going to close on its own and it should be fixed. I see people sometimes because the pediatrician freaks out because it looks like the little bubble popping out of their belly button when they cry or when they push really hard to poop, but they're 8-10 months old. Give it time. It almost always, if it's less than 2 centimeters in diameter, so about the size of a dime or almost maybe a nickel, as long as it's about the size of a nickel or less, it should close up by itself by the time they're about 2 years old.
We're talking about belly button hernias in little kids and babies.
Right.
By the way, do you know where belly buttons go when they retire?
I'm
The
scared to
naval
ask.
reserve. The naval reserve. Yes. Anyways, okay. What about hernias in the groin region?
I love how we do dad jokes in amongst the podcast.
Yes,
That's
that's
awesome.
part of my shtick, Dr. Rock and the dad jokes. But tell me about this. So I think a lot of people think of belly button hernias when they think about hernias, but I think they also think about inguinal hernias or the ones in the groin. And then that can be scary because sometimes people don't know if it's a lymph node from some sort of infection or an STD, or do they have a cancer? So tell us about inguinal hernias or groin hernias.
You bet. So inguinal hernias are interestingly not a tear, not a injury. So for men, testicles, when you're inside mom, when you're a fetus, when you're a baby growing, the testicles are actually inside the belly and they have to come down a certain tube, so to speak, a canal, a hallway to get down into the scrotum. And so that's that undescended testicle, or have the testicles descended. Most people have heard of that term. That's where the testicles are in the belly and they drop down. They drag with them their blood supply. So there has to be a break in those muscles that come together from your belly. You have the ones that make the 6-pack that I'm sure Dr. Kettman has 8 of them, and then the ones from the sides that come in, and that's the obliques that give you those nice small waists and all those kinds of things. All those muscles come together at that bone that's right in the front called the pubic bone. And they attach there, but they make a bowl in your pelvis, in the lower part, like around your hips. And there's a natural way those are shaped and come together so that the testicle and its blood supply can come down into the scrotum. Then the hope is over some time as babies grow, when they're growing up, that space just becomes really narrow so that the only thing that can come through there is that blood supply and something called the vas deferens, which carries the sperm, which is when you get a vasectomy, that's what you're cutting. So all of those structures come through that very small space. Women obviously don't have anything going anywhere. We have the same muscles, but that space doesn't have to exist. And so that's why groin hernias in women are incredibly rare, not impossible, but incredibly rare, because we don't have a natural gap in those muscles to allow anything to go through. So then you add growing up, getting bigger, getting older, and internal abdominal pressure, chronic constipation, heavy lifting, pregnancy in women, obviously, anything that causes people who have COPD or lung disease where they cough and cough, smokers who cough and cough, Anything that's causing a lot of enteral pressure or you're squeezing so hard all the time, like the heavy lifting. Honestly, thank goodness for John Deere. They keep me in business. I do a lot of groin hernias from John Deere because they lift 100 pounds on the line all day long, every day. Anything that's causing that kind of pressure can cause the path of least resistance. So you're pushing in your abdominal wall, and here's this natural gap, and things just spread out more. And now you have fat or intestine that can plop down into that space and get stuck. Again, it's a narrow hallway. It really hurts. It causes pain. Most people know they have it. They'll often describe a bulge where there wasn't before because that muscle has now allowed something that shouldn't be there to come through that space. And so, again, if you own a hernia, groin hernia, you should fix it because, again, if bowel gets stuck in there, really stuck, bowel can die. And then,
even if it's not bothering you, you should get it taken care of.
correct. The caveat with the not bothering you is you have the luxury of some time. Tell a story. I'm not from, like I said, even though I'm from Texas, I'm a city girl. This whole rural world is completely new to me, and this fresh air. I'm a smog breather myself. So I had to learn that life is very different here in a rural type community. So I met a gentleman who I met him probably about early August one year. This is when I first got to town, and he was a farmer, and he had a groin hernia. It didn't hurt him. It would pop back in. So that's one of the key points is, does it come and go? When you wake up in the morning, it's not there. When you're running around all day or you're lifting, bloop, it pops out. You could lay down on your couch, gently put a little pressure, bloop, pops right back in. If it's coming and going, again, while not immediately dangerous, it's coming and going, and things are not going to get any better. Hernias don't heal by themselves. Once the gap is there, the gap is there. It's never going to get any better. So anyway, so I met this gentleman, and he had this hernia. It didn't bother him. It didn't hurt. And so I told him, for me and my colleagues, we don't all agree on this, but I guess I'm a little more conservative because I figure, hey, why not treat it right the first time? I make my patients go to a 10-pound weightlifting restriction for 6 weeks. So nothing more than a gallon of milk. And so that's obviously very cumbersome for people who, once I fix the hernia, not while you have it, but when I fix it, because I want you to scar down using the mesh that we use so that you make a nice, big, flat, wide scar that makes this hernia never come back and you don't have problems with it anymore. And that's never is an extreme word. Anything can happen, but most likely will not come back if you've treated it right during the healing process. So he said, I got to harvest soon, and then a pheasant hunt, and then a deer hunt, and then an ice fish, and then I got to plant. So how about May? I said, sure, no problem. As long as you're not having pain, we can wait. And I would rather wait until you can do it and you can commit 6 weeks of your life to, you can walk around the farm, you can drive, you can walk up steps, but you're not picking anything up. And that's what we did. And he did great. And I said, if anything changes, if it gets hard, it hurts, you feel like you can't poop, you call me and we have to do this a lot sooner.
Okay, that was a great story, by the way. I love that. Okay, what should we talk about next?
You already stole my thunder on the poop because I was going to talk about constipation, and I look back and like 2 episodes ago, you did constipation.
Hey, yeah, thank you. I did actually, but I don't know if I did it right.
I'm sure you did.
Anyways, but I did use the constipation movie joke. Have you seen that movie? No, it hasn't come out yet. Did you hear that one? Yeah. So a movie called Constipation. Anyways, I've used that joke too much, but Quinn will have this part on it. Yes. Why don't we talk? I think hemorrhoids are a big interest. I'm going to ask you about that. And then about 10 minutes from now, I'm going to ask you, and just start thinking about this, the question I ask everybody, which is, you had one message for the world to share today. And actually, it doesn't have to be one because you're such a good guest. You talk well and enough. And I don't have to drag anything out of you that I need you on this again because there's a lot more to talk about.
More editing.
No, we got so much content here, but I think hemorrhoids are big. What else is your most common bread and butter? Appendix, I think everybody.
Yeah, I think hemorrhoids and diverticulosis go together because the cause is the same. Yeah, I think those are.
Can we talk a little bit about hemorrhoids or diverticuli today? I have some questions about that. Oh, that would be great. Can you explain to the audience? I know you deal with both. Let's start with hemorrhoids. I think people are very familiar with that, but aren't really sure what can be done about it. And so what's a hemorrhoid and how do you deal with it?
You bet. So I'm going to kind of lump these together a little bit because they have a similar origin of problem. And that is most commonly constipation, most commonly from a low fiber diet. I've seen more diverticulosis in the Midwest than I've ever seen in my life. So in my training, I did part of my training.
What is diverticulosis?
You bet. So diverticulosis are these little pouches that occur in the colon due from increased pressure. When I have pieces of paper and draw it, I draw it for my med students. I can get real geeky and tell you exactly where it is and why if you want me to. But usually for most people, they experience it on the left lower quadrant. So that's called the sigmoid colon. And the
right towards the end of the butt.
Nope, more like if you're looking at the front of your belly, like where your appendix would be on the right side, it's on the left side.
But it's getting towards the end of the line before stuff comes out. Yes.
Correct. Yep. It's the kind of the last segment before the rectum, if you will. And the rectum is just the pouch that holds the poop till you're ready to go. Yes. And it's a kind of the reason it's named sigmoid, it's a fancy term for S, and it's in a kind of an S shape. And what's interesting about this part of the colon is every other part of the colon, every other part is attached in at least two different sides. So either attached to the abdominal wall and attached to its blood supply in the center. In the transverse colon, the one across the top, the one in the middle, it's actually attached in three different places. The omentum, which is this big fatty layer that lays over your guts and protects them like a giant cushion, and the abdominal wall and the stomach and its blood supply. The sigmoid is only attached in one place, and that is to its blood supply. So it is floppy, and it is allowed then when you're pushing really hard or lifting really hard, it's allowed to feel a lot more force. It's torque, if for all of you motorhead geeks out there. So it's more torque in this portion of the colon than anywhere else. And so because of that,
is colon torque a good band name, and can I have it?
It's all yours, buddy.
Thank you. Sorry to interrupt. All right.
Colon torque. Yeah. Yes. And diverticulosis needs to be one of your songs.
Okay. Thank you.
But anyway, so because of that, where the blood vessels come into and feed the most internal lining. So the colon's made of layers. The most internal layer, it's called the mucosa, and it's the part that absorbs all the water. The colon's only job is water recycling plant. It doesn't do anything for you in nutrition. That's all happens in your small intestine. It is just a water recycling plant so that you don't have to drink 47 gallons of water a day. It sucks the water out of the small intestine, turns your stool into solid so that we can manage it, and helps you, again, rehydrate more than. So can you live without a colon? Absolutely. You'll have a whole lot of stuff coming out of the bag in the front, but you can absolutely live without a colon. You cannot live without your small intestine because that's where all of the nutrition, all of the absorption of vitamins and minerals and proteins and everything happens. So you can't live without your small intestine, but your colon, you just have to drink more water. So back to diverticulosis. So what happens is the blood vessels that feed that most inner layer have to puncture through all of the walls, and it makes like a teeny tiny little hole or a weak spot. When the colon feels all this pressure, whether that's lifting, constipation, or whatever, that spot is weaker. And so again, we're back to path of least resistance. It bulges. It's literally almost like a tiny hernia within the colon because it's these little bulgy spots. That makes this little pocket, and that pocket can catch stuff, little stuff. That's where they talk about seeds and nuts and popcorn and corn. Sadly, we live in the Midwest for corn. And all of those little things that can get stuck in those little pockets. And then what happens is that sort of festers there and can get infected and can even pop and burst, called a ruptured diverticulum. And you end up with the diverticulitis. That's the infection of those little pouches. Diverticulosis means you own them. If you have a ruptured one, it can leak poop juice into your belly. As you can imagine, that's real bad. And people get real sick. Sometimes that requires an operation. Sometimes it just requires a little bit of time. Your body will try to seal it off if it happens in the right place and there's not a lot of leakage. So that's handled in kind of its own special way. But all of these things are also related to hemorrhoids because, again, it's that internal abdominal pressure of pushing that either you're lifting really heavy, you're giving birth. That's where most women get it, is after babies, or for guys who work heavy or cough a lot. They're all related to the same pushing of abdominal pressure, constipation. Those kinds of things can result in hemorrhoids. Hemorrhoids are just a varicose vein of the bottom, for all practical purposes. It's just a blood vessel that is gotten just like standing and you get them in your legs, pushing really hard, you get them in your bottom. And so they are a blood vessel. They come in two flavors, if you will, internal and external. Externals hurt, generally don't bleed. Internals bleed and generally don't hurt. How do we handle that? Carefully. So I tell everybody, if your life is not being ruined by them, you don't want an operation for them.
What would they get? I've heard the recovery and the surgery is terrible, but what would make somebody seek treatment for a hemorrhoid?
So anytime one of the things we mentioned earlier is bleeding from the bottom or blood in the stool makes everybody scared. You think you're going to have some sort of cancer. It is good to go have somebody look at it. But the most common cause of bright red blood, looks like you just cut yourself, is a hemorrhoid from the inside. So that layer over that blood vessel, because that blood vessel has been stretched out, is like 1 or 2 cell layers thick. It's very thin. Then you have a big hard stool come down and it breaks it over the coals, if you will. You bleed a little bit. You've busted this thing open. It doesn't hurt because it's above the level where there's nerves, but it bleeds a lot and it scares everybody. And so they come in and we talk about it. And what I tell people is, if you're not on a blood thinner, so that would be a reason that would be more important to operate on those people, because that bleeding doesn't stop. You're not on a blood thinner, the bleeding, okay, you notice it when you wipe, or you notice a little bit in the toilet. Now remember, a drop of food coloring in a bowl of water looks a lot worse than it really is most of the time, but a little drop and you're like, and it stops and it doesn't come back. Obviously go get it checked out. But once you know that you have hemorrhoids, if it's not all the time, it's not soiling your pants, honestly, once you know that it's a hemorrhoid, I wouldn't do anything about it. You don't really have to. Surgery for internal hemorrhoids, is the recovery is markedly better and markedly easier, but usually those blood vessels connect to the ones to the outside. Rarely do people have just internal. They also have the bulges on the outside. Most people come to me because those get thrombosed, get a blood clot within them, again, from pushing, that sort of thing, and they get horribly painful. I think there's more nerves around your butthole than anywhere else in concentration in your entire body.
My butthole?
Everyone's butthole.
Oh, gotcha. Okay. How do you know that about me?
Because I dissected it.
Oh my God.
It is such a sensitive area, more than you realize, and it is horribly painful when people have thrombosed hemorrhoids, or that hard, when it's a bump that's hard. When they're soft and squishy, people don't like how they feel. They feel like they can't get clean. I'll get people come in, especially women. Men seem to not mind the skid marks. Women tend to be bothered by skid marks. It's a funny thing. And so the women come in, I just can't feel like I get clean. It's like a Shar-Pei back there. There's wrinkles everywhere. And I can't deal with this anymore. And if that's your only problem and it doesn't hurt and it doesn't inhibit your life, what I tell people is, number one, baby wipes. Baby wipes are your best friends. They get you cleaner with less work. You're not rubbing everything and getting things inflamed and angry. And honestly, the better than even that is sounds weird. We're not English and we're not French and we're not European, but I'm telling you, you can buy these seats on Amazon and they will save your life. They're wonderful. I always know who's pooping in my house because they're sitting in my bathroom. That includes the teenage boy. So they're just showering off that area. So you're, again, not rubbing things to make things inflamed. So when they're hard, when they hurt, sometimes there's not any other way to take care of them but a surgery. But I tell all my patients, you have to pretty much beg me to do it. It is the most painful, uncomfortable, horrible, pooping razor blades. Again, don't do it because it looks funny. Don't do it because you don't like the way it feels. You do it because you can't sit down. You can't enjoy your friends. You can't go to church. You can't enjoy your card game. You can't live your life because you're in so much pain. Okay, then we're back to that risk benefit ratio conversation. Now, the risk is worth the benefit that you're going to get out of it. Is it because you don't like the way your butthole looks? And I've had people come to me say, I just don't like the way it looks. I don't know who's looking at it, but they just need to get over it, because it doesn't matter if it's such a painful operation. The recovery is so awful. You don't want to do it if you don't have to.
Got it. A couple more questions. I got a patient coming at 2:20, and then I have band practice at 3 something. Okay, so I want to ask about.
I want to add.
Not,
hang on a
go
second. I'm
ahead.
going to add one more thing.
Yeah.
The one big plug I want to tell you is, most of the time, this is a problem of a low fiber diet. This is not enough fruits and vegetables. And granted, even vegetarians can get this who eat lots of fruits and vegetables. If you eat a lot of cheese or constipating foods, that can certainly contribute to this. And lastly, worst case scenario, take a fiber supplement, Metamucil, Benefiber, Fibercon, something, but fiber and more fiber is almost always the answer, because I've never seen all of these problems so much in the Midwest where they think corn and potatoes are vegetables. They are not. They don't do anything for you nutritionally or for your colon. I'm talking broccoli and cauliflower and carrots and all that good stuff that your mom always made you eat.
Got it. Do you think, here's another question. Some people are very concerned about constipation, especially senior citizens. I think their fear is it's going to lead to a small bowel obstruction, or a bowel obstruction, as they call it. I got to take a laxative so I don't get a bowel obstruction. Is that a thing?
Yes and no. First of all, laxatives are great for a rescue medication. They should never be a daily medication. Anything Miralax, X-Lax, Gocalax, anything with LAX, what that's doing is a muscle stimulant to the colon. It is not doing anything for you but taking over a function God intended. And when we do that, those parts quit working. And it's really important that you let your colon do what it's supposed to do, which is feel a stretch, which means poop is nice and soft and fluffy, and then move it along in its own contraction the way it's supposed to. And that is stool softeners, docosate, something that is not a laxative, and fiber. Fiber and docosate just hold on to water inside the poop and make the poop go, oh, gee, there's something here. I should move things along. Colon walls are really wimpy. Their muscles are really wimpy. If it's really hard, it can't move it along. And it's sucked out the water and sucked out the water and sucked out the water until it's petrified. And now we have the problem of you can't move it. That's when laxatives come into play, but they should never be a daily medication. You should get control of your poop when you can. Now, there are people who have slow transit colons, diabetes, various other things. There's other medications that can be used for constipation, but 90% of the people I see, it's because they don't drink enough water, they don't eat enough fruits and vegetables, and they don't take stool softeners if they need it.
Got it. How about in the nicest way possible? I'm going to ask you, what are some primary care mistakes?
Sending me
So,
someone.
so as a primary care doctor, I'm always looking to the best way to learn is from other people's mistakes, right?
Absolutely.
So you don't have to repeat the process yourself. So what are some things that sometimes primary care doesn't get right that you see in your world that could help strengthen me in my practice and the patients that are listening?
Sure. Probably the two biggest ones. Number one is prescribing laxatives daily. I hear all the time, my doctor just told me to take Miralax every day and I would be just fine. It's common in the farming world because they don't want to have to leave the farm to go poop. They take a laxative in the morning, they poop at home, and then they can go on. And their doctor said, oh, a little bit of Miralax will be just fine. Anything with LAX is a muscle stimulant and can cause what is termed, people heard, addiction to laxatives. What that means is not addiction, but it is the nerves actually dysfunction and can even atrophy, just go away in the colon when you're chemically taking over a function that is supposed to be a reflex in the body. And so fiber, fruits and vegetables, or stool softeners, which also work as like holding on to water, is the thing that drives me crazy. Is I get people all the time say, my doctor said Miralax was gentle. It is if you need it as a rescue medication, you haven't pooped in 3 days, your belly hurts, fine, take that. Never, ever as a daily medication. And it happens in this world, in this part of the country, more than I've ever seen in my whole life.
Yeah, actually, I was trained that Miralax is the safest that you can do. And they give it to kids all the time with chronic constipation, pediatric gastroenterologists and stuff. So that's interesting to hear that. What are some other common mistakes in primary care? Like telling somebody that even, for instance, I always worry about like someone saying, hey, I can't feel a breast lump, so it must be okay. Or tell me what other primary care doctors make maybe misconceptions that lead to bad outcomes.
Sure. Ignoring hernias, being told that it doesn't matter, ignoring any lump, frankly, of any kind up to a point. It's always better for some surgeon to go, hey, it's a lipoma. That's a little ball of fat. It's no big deal. Let somebody look at it. Breast, especially, any lump in the breast. Now, breast lumps are incredibly common in the younger population. We have denser breasts. Then when you get older, doesn't matter. If there's a lump there now that didn't used to be, please go see a specialist or even your primary care doctor. But any lump is not okay. Anything that's new to your body that didn't used to be there, whether that be dark spots, like we talked about, ignoring a mole that's getting bigger. Ignoring things generally is a bad idea, just across the board.
And not a good defense mechanism.
Yeah, it's also hard to defend in court.
Amen. All right. Awesome. That was gold right there. I'm just going to ask you about what you want to say to the world. So just think about it. Even if it's fiber or if it's Jesus Christ or whatever, I'm going to give you a few minutes. I've had all kinds of different responses for this one. It could just be some positive advice, pick yourself up by your own bootstraps kind of stuff, or
Wow, that's
it
awful
can be
big.
medical, or it can be a story from your own trials you've overcome, whatever you want.
That's way too broad. You're going to have to narrow that down.
Okay. So I'll just ask the question and then you take your time. All
Okay.
right. Okay. So now we're at that part of the show where, the message I'm trying to get across to better outside the box healthcare is to get people's lives better, whether it be medical, physical, social, economical, whatever. I'm interested. If there's one piece of advice that one of my guests has that can help one person or the whole world, I want to get that out. And you've already given a bunch. So don't feel like you have to go over the top here. But what would if you had that stage for my audience or the whole world, what would you say?
Such a big question. Thanks. I guess where I would go with that is be accountable for yourself. And that, whether in all of those realms, whether that is your own personal health, such as exercise, fruits and vegetables, drinking water, whether that's your spiritual health, if you have some sort of religious preference or beliefs, get involved in that sort of thing, if it's social things. But what I see most often is people coming in, and I think it's worse in America than anywhere else, is they want someone else to fix their problems, whether that be financial problems or any other problems. And at the end of the day, we're responsible for ourselves. And that is your own health, your own finances. If You don't feel like you make enough money, get a better job, get another job, get a better education. I was always raised that it's up to you. And I think that we've lost that sometimes in America. We think that somebody's supposed to do everything for us, and we've become quite not lazy, but just that world where somebody owes us something or somebody else is supposed to do it for us. Give me a pill or a shot to lose weight instead of getting on a treadmill. Not to bash the GLP-1s, there it is. It's you don't see heart disease in Italy where they eat tons of cheese and tons of pasta and drink tons of wine because they walk, they exercise, they de-stress by not living the crazy lives that we live, the speed at which we live them. Everybody has to be honest about what makes them tick and makes them happy. But at the end of the day, the only person that can do it is you, and in whatever realm that works for you. But having somebody else blaming other people to be responsible for yourself, only you can do it. And if you don't know about it, get educated on it or ask other people to help you become educated, because you can't know everything yourself. But chances are high you know somebody who knows somebody who can help you learn more about how to be better at whoever you are.
Nice. I love that. Dr. Melissa Garrett. Amazing show. Thank you so much for being in the mosh pit here on Dr. Rock's Family Practice.
Thank you so much for inviting me.
Oh, you going to come back for us? Because I have a lot more questions. And this was very interesting, satisfying, intellectually amazing, and it's going to help a lot of people. Can you come back sometime?
Absolutely. Love to.
I love it. I had such a good time. And to my audience, I just want to say thank you for tuning in again. This has been another episode of Better Outside the Box Healthcare with Dr. Rock. This is Dr. Matthew Kepman with Dr. Melissa Garrett here saying, get better, take care of yourself. I'm praying for you. I love you guys. Take care. God bless. Okay. Thank you. Yeah, it should come out probably Wednesday. Oh, okay. Wednesday or the next Wednesday. I didn't know you were coming to, well, asking there. So I'm not even sure I'm going to put you on Crescent at all. Is that new? No. Yeah. So I'm not even sure I'm going to. Hold on a second. Let me just get rid of this podcast recording. That was this